Next up with our PQI clinical overview is Michelle Phillips, clinical specialist from the University of Rochester Medical Center. Michelle will speak about the PQI that she wrote on Niraparib dose adjustment based on weight and platelet counts. Michelle.
Hi everyone, thanks for joining in. The purpose of this PQI was just to provide a summary to aid in the dispensing and management of patients taking Niraparib. For those of you that aren't aware, Niraparib is a PARP inhibitor that is indicated for the maintenance treatment of patients who have recurrent epithelial, ovarian, fallopian tube, or primary peritoneal cancer after a complete or partial response to platinum-based chemotherapy. PARP inhibitors induce DNA damage by cell death by taking advantage of deficient homologous recombination repair. And while this tends to be more pronounced in patients with BRCA1 or 2 mutations, it also has benefit in patients without BRCA mutations as well. Listed on this slide are the common adverse reactions occurring in patients taking Niraparib from the phase 3 trial comparing Niraparib versus placebo. So you can see the side effects listed there. The grade 3 to 4 nausea occurred in about 3% of patients. So you can see that while this is a very commonly reported side effect, it doesn't tend to be severe. In terms of thrombocytopenia and anemia, grade 3 or 4 adverse events occurred in 34% of patients and 25% of patients respectively, which illustrates why these tend to be dose-limiting toxicities. On the initial fill, the labeled starting dose is 300 milligrams. However, you may see 100 milligrams or 200 milligrams used at baseline in clinical practice in patients with certain clinical characteristics. So this includes patients weighing less than 77 kilos or with platelets less than 150 at baseline. In clinical trials, patients with either of those two characteristics, only 17% of those were able to remain on that full 300 milligram dose by month 4. Furthermore, the NCCN guidelines recommend discontinuation of bevacizumab before maintenance treatment with a PARP inhibitor. This isn't in the packaging information. However, there are some evidence out there that was presented at ESMO in 2017 that the combination is safe and effective. So I wouldn't consider this an absolute contraindication. The recommended monitoring is listed on this slide as well and includes weekly labs for the first month, followed by monthly labs for the first year thereafter. And then due to the risk of hypertension and tachycardia, assessment is recommended at least monthly for the first year of treatment. If patients are unable to recover from an adverse effect within 28 days of holding treatment, it is recommended that Niraparib be discontinued. In addition, a maximum of 2 dose reductions are allowed with a minimum dose of 100 milligrams per day. So if a patient's experiencing a grade 3 or higher adverse reaction, they should discontinue if they're unable to tolerate that minimum dose. For any grade 3 or greater non-hematological toxicity, it is recommended to hold the medication if the symptom is not responding to supportive care or prophylactic measures. This slide is useful for a quick reference for the management of hematologic toxicities. I'll go over the platelets in detail. So for example, if patients develop a platelet count of less than 100 on treatment for the first time, you will hold until the counts recover to greater than or equal to 100. If they drop to less than 75, you may consider resuming at the same dose or reducing depending on how low that nadir was, and that's just left to clinical judgment. But after the second occurrence of a platelet dropping less than 100, you will be required to dose reduce the medication. Similar management listed here for neutropenia and anemia. And this is more specific if the patient does develop neutropenia with an ANC less than 1 or hemoglobin less than 8. You will hold until recovery, and then you will dose reduce by 100 milligrams per day. All right, so we've gone over how to initially dose and how to adjust the medication. So listed on this slide are the important counseling points for us to relay to our patients. First, the medication can be taken once a day with or without food. It is listed as a moderate to high metagenic potential for the NCCN guidelines. So you may consider recommending prophylaxis, particularly in a patient with a history of severe nausea and vomiting. And there are some evidence out there as well that taking it at bedtime may also minimize the nausea. The warnings that we need to provide to our patients so that they are aware include MDS or AML, bone marrow suppression, cardiovascular effects, so specifically the tachycardia and hypertension, and embryo-fetal toxicity. Because of the high risk of constipation, prophylactic use of stool softener should also be recommended to patients with the addition of laxatives as needed. So in the interest of time, I won't read through this slide, but this just contains resources to assist patients to obtain their medication while either waiting for prior authorization or copay assistance through that Quick Start or Bridge program. And listed here are both manufacturer programs and foundation assistance when available. And at this time, I'll take any questions.
Awesome. Thank you so much, Michelle. Before we get into some questions, I would like to mention that you can also find Niraparib financial assistance information on the Untitled website under the Member Resources tab. There, you can then select financial assistance and search Niraparib in the search box. We will now open it up for some questions. Looks like we have one come through the Q&A box, Michelle. Our member asks, once a patient has been reduced, do they usually stay there or do they go back up to the 300 milligram dose?
So I think the recommendation is to keep patients at that same dose once they have been dose reduced, particularly if it was due to a side effect.
Okay, great. Any other questions? All right, and if you do have any questions for Michelle, feel free to email contact@encoded.org and we will be sure to get you an answer. So thank you again, Michelle.
Thank you.